Good morning, everyone, and welcome to our Regional Geriatric Rounds webinar. At today Regional Geriatric Rounds, Dr. Sokolowski will be presenting on the dignity of risk and hope. Dr. Sokolowski is the co-director of ethics at Baycrest Health Sciences and a member of the University of Toronto Joint Centre for Bioethics. She is assistant professor of the Department of Medicine, Faculty of Medicine, University of Toronto. And previously, she was a clinical ethicist at Bloorview Children's Rehab and Trillium Health Center, following a clinical ethics fellowship at Baycrest Health Sciences. Dr. Sokolowski has a master's level diploma in assessment and counseling from the University of Toronto, a master's degree in philosophy from the University of Guelph, and a doctorate in philosophy from the University of Waterloo. Her current research practice areas in ethics includes war trauma, end-of-life issues, use of palliative sedation, feminist ethics, neuroethics, interdisciplinary ethics, and organizational ethics, advanced care planning, sexuality issues amongst residents with dementia and long-term care, and ethical issues related to alternate level of care are of particular interest and focus for her. So welcome, and we look forward to a very interesting presentation.
Thank you so much. I want to thank Stephanie for the invitation to present and Heather for the kind introduction. My presentation includes many thoughts as the ethicist on the case that we will be discussing. We will be, of course, allowing ample time for participation on your part, as this case is very complex with a number of layers, and I'd really appreciate your reflections and thoughts. This is an evolving case, so it is ongoing. One of the purposes of today is to identify the many challenges that we face, and we will be raising many ethical issues and questions for further deliberation through this presentation. As the title suggests, notions of dignity, risk, and hope fare very large in this case and presentation. Next slide, please. I have no conflicts of interest to declare. Next. The learning objectives for today include understanding and applying the concept of dignity of risk and hope to the case. So hopefully we will have a better understanding of what does this concept even mean, and try to deliberate it a little bit more further. We will be identifying the salient principles and values that pertain to the case, and in particular looking at what to do in situations when principles are in conflict with each other, and how do we decide, or values are in conflict with each other, and how do we go about deliberating how to, which principles or values are actually going to trump or should trump, case by case. We'll be looking at understanding the criteria and role of capacity from a legal perspective as well, and its applicability to this particular case, and we'll see how complicated that actually ended up being. And probably first and foremost, although it's written here as the last bullet, appreciate the patient's narrative in view of treatment decision making. And I think this is a really, really important learning objective, and it's very much aligned with the whole notion of client or person-centered care. Next slide, please. I've identified Baycrest principles because that's where I work, but I think if you think about the principles as we go through them, and put some thought to which principles do you adhere to individually, professionally, as well as personally, and which one are ones would trump in the case of conflict between them. So it's an opportunity to just reflect on your own personal perspectives on each principle. So as we review these principles, and we will be looking at values following the principles, please keep the key elements in mind so you can apply them to the case at hand we will soon be discussing. As I already referred to, patient-centered care increasingly guides healthcare practices, and I think it's important to ask, well, what does that really mean? And how does it influence, or how should it influence our practice? So the norm of respect for patient values may test the familiar limits of risk management and patient safety in new ways. We will see this in the case where the patient's, let's say, appetite for risk is much greater than any of the staff members in relation to a particular treatment that he is requesting. And we will see how that gets played out. And what should be the limits to patient preferences? We talk about patient-centered care, but what are the limits, if any? Next slide, please. I'm quite sure that that everybody is well aware of each of these principles, but again, I'm inviting you to think about them in a deeper way in terms of what are the principles of the organizations that you belong to, and also your own practicing principles. You know, how do you customize them for yourself when you're faced with treatment decisions or care of people? Autonomy. Well, we know that everybody has the right to make their own decisions and to have his or her choices respected as long as nobody else is put in harm's way. I think the whole notion of clients' wishes will be solicited whenever possible when planning care and treatment, you know, can't be emphasized enough. Next slide, please. Beneficence. Each staff member is obliged to do good to promote others' welfare and well-being in accordance with their professional code of ethics. Now, it's always somewhat of a challenge to be able to define good from whose perspective. What does good actually mean and in what context? And it's certainly very usual to have staff differences between them with regard to what is a good on any specific case, realizing there may be multiple goods and potential conflict between these goods. And then, of course, we have what is a good from essentially from the patient's point of view, and also from maybe substitute decision makers, family members, etc. So as you can see, there's a lot of potentiality for conflict between actually operationalizing, defining good and then operationalizing it as well. Next slide, please. The principle of non-maleficence is a very, very important one as well. And this is the obligation to try to either not do harm or to prevent harm. And it's linked to beneficence when staff are not doing evil or causing harm, or preventing evil or harm, or removing evil or sources of harm, and thereby promoting good. Again, the same question, just posed a little bit slightly different, is begged, which is, what is harm to the patient? From whose perspective or perspectives are we establishing what the definition of a harm would be and what its, again, operationalization would look like? What to do when we have various definitions or ideas of what harm looks like, and whose perspective ought to be trumped. Next slide, please. The principle of veracity, another very important principle. Each person is entitled to be told the truth to the extent he or she wishes to know it. A relationship based on truth and sharing information in an objective, accurate, and comprehensive manner fosters trust between clients, families, and healthcare professionals. So this mutual trust is the essential element in relationships that we are forming to meet the common goal of enriching the quality of life of the client, providing the highest quality of care. So here we get into notions about what the actual truth, which I put in italics, is. As you'll see when I present the actual case, what the patient believes to be true about his prognosis and what the team members believe to be the, quote, truth, do not align with each other. And we'll see sort of the drama that unfolds, so to speak, as a result of that. Next slide. So these are Baycrest values, and again, you're going to be representing different organizations as well as have your own sort of sense of what each value means from a qualitative point of view. For Baycrest, I've just put these up really as an example, but this is the organization that this patient is a patient at, and this is where I work, and I have to ensure, certainly as an ethicist, that I am aligning any kinds of work I do with the values of the organization. So you can see them here for yourselves. And what I do is, is invite you all to consider your professional organizational values. You might want to compare these to yours, where you work, your college's values, and your own personal and professional values, and how they would influence your treatment decisions and medical approaches when you hear shortly about the case at hand. Which values might be clashing with each other? Which would trump if you can't reconcile the values clash? I've been in a number of consultations where it becomes very difficult, if not impossible, to reconcile values sometimes. And sometimes we're pushed to the very hard decision, okay, which one's going to trump in this very particular situation? And that is a very, very hard challenge to have to meet. Next slide, please. So as I think is pretty obvious by now, this case centers on identifying which actions, care, and treatment plans are morally justifiable in the face of a client's desires. When in this particular case, what is really salient is that the client's desires, when we look at the client's desires, we see that the risk levels that he is comfortable with and wishes to operationalize, let's say, feel very uncomfortable for the staff. So, as I've already mentioned, we have to think about risk in terms of, or whatever values, principles we're looking at, but also this notion of risk, I think, is in itself undervalued as something important to consider when we are faced with consultation around treatment and care. And I think we have to view risk in terms of the organizational principles and the organizational, professional, and personal values held by the client. Which principles are the most salient? Which values are the most salient? And what role does risk play? What role ought it to play? And how does this sit in terms of where the client's narrative is, what the client's story is, the client's comfort or appetite, so to speak, for risk? Next slide, please. So now let's have a look at Mr. Wilson, and I hope that as we go through this, I invite everybody to consider what values and principles do you think are coming to the fore as you hear the description. So Mr. Wilson is a 66-year-old male. He's a musician in a band, or used to be, and he was admitted to complex continuing care at Baycrest in the fall of 2017. He's a widower. He has 5 kids and many grandchildren, and very connected to his family. They visit often. His past history includes diabetes, hypertension, coronary artery disease, cerebrovascular. He had a cerebrovascular accident in 2008 with left-sided hemiplegia. Following a stroke, he was using a cane. He had an electric wheelchair that he could use on his own with some, and he also had some personal support workers' assistance as well. Next slide, please. History of present illness, April 2017. He was admitted being unresponsive to the emergency room and diagnosed with sepsis, rhabdomyolysis, acute kidney failure, and atrial fibrillation. He was admitted to their ICU and he needed dialysis. There were a number of complications, unfortunately, that arose, including tracheostomy, difficulty being weaned from the ventilator, and ongoing congestion. A feeding tube, next slide, thank you. Feeding tube was inserted and right-sided above knee amputation occurred for gangrene, and this was the good leg. So then there was the admission to our facility, and that was April 2017. So he came with the tracheostomy, he came with the feeding tube, he required total nursing care, excuse me, and he had decreased alertness. We called psychiatry as he was on an antipsychotic, and there was a question also about whether he was suffering from depression. Next slide. With the tapering of the antipsychotic and starting a Zoloft, his alertness and ability to answer questions improved quite a bit. Eventually, he started talking on his own and showed no signs of depression. And recently, there was a further tapering and then finally discontinuation of Zoloft. His mood had really got much better. So in terms of intercurrent illnesses, we have sepsis, Clostridium difficile, congestion, and pneumonia. Next slide. It's always very important, and we are engaged in pretty high levels of advanced care planning at Baycrest, where, of course, we look at it as a process and not a one-time situation where we ask people about their goals. But what became evident from discussions with Mr. Wilson were the following. He wanted to be corked. He wanted to eat certain foods. He wanted to return to his former self and functioning level as a musician. He wishes eventually to have decannulation, removal of his trach, despite concerns by ENT on examination and recent pneumonia. He wishes to be independent in an electric wheelchair, walk with a prosthetic, play guitar and piano. So he was corked for a period of time. He did well, and he actually is now decannulated. He was found to be capable of consenting with regards to this and chose to go ahead in light of the risks. Now, please note what's bolded here is that stated that even in the case of 95% chance of further pneumonia resulting in death, okay? So in the case of 95% chance of further pneumonia resulting in death, which is what he was told could be the case. You can't know, of course, 100%, but it would not be unusual. He chooses this risk because he is focused, he says, on the 5% chance that he would be okay. Now, I think it's really important to pay attention, or I invite people again, to pay attention to our own subjective thoughts and personal reactions when we hear this statement. There's going to be a number of different reactions. Some staff felt he was not thinking clearly if he was willing to gamble at a 5% success rate. Others thought, well, that's just peculiar to him. Not that it's peculiar, but what I mean by that is that's you know how he feels, and that's totally fine. Everybody has a different risk appetite and attitude towards risk. And that this just illustrated his optimistic nature. So the point here is that it's really important to pay attention to how our own values and beliefs play a part in the interpretations that we make, because they very much influence how we're going to respond when we're having a conversation with patients in these kinds of situations. So again, I think this is really important, how he feels that he's a gambler. He's going to take the 5% chance because he felt very optimistic and believed that he would be okay. Next slide, please. There were assessments that were done related to his wish to walk and to use the electric wheelchair. But his assessment for the prosthetic indicated he's not a candidate and advised this by both OT and physiatry. He has certain visual impairments that would preclude him from operating an electric wheelchair on his own. It would not be safe to himself and particularly to others as well. Next slide. So, in terms of his response to the assessments he had, and of course, you know, each of the specialties involved spoke with him and explained their assessment results to him. He still continues to want his electric wheelchair. He is certain he's going to walk. His overriding goal is to remain very positive and hopeful, to beat the odds regardless of the risk. He says that he talked about in trying to understand his story And really the story of what we got to learn about his parents and grandparents as well from an intergenerational point of view was there was a real legacy of overcoming obstacles. And this, when he actually said that his stroke was a stroke of luck, which is a very interesting way of understanding when one has a stroke. It's not necessarily a very common interpretation that one would hear, but he felt very strongly that his stroke was a stroke of luck, of good luck, as it allows him to really appreciate his life on a day-by-day basis, appreciate his family. And he's adamant that this is the core of his identity, to be optimistic regardless of risks. And this is at the core of who this gentleman is. And I can't overemphasize the importance of trying to really appreciate and understand where he's coming from and not discounting it. In fact, he told his brother not to visit anymore because he believes his brother to be negative and lacking of hope. And he found it so disdainful and difficult to maintain his position and his optimism when his brother was around. Next slide, please. So I'm hoping that the audience here, that you are having an opportunity to sort of gauge what your own thoughts, values, feelings are when you hear about his narrative, when you hear about what he believes to be true for himself and how passionate he is about his relationship with risk and how much it influences how his sense of dignity, his sense of being true to himself. Now, some feel that Mr. Wilson is very unrealistic, that he doesn't truly appreciate. Now here we're going to get into the notion of cognition and capacity. That he doesn't truly appreciate the nature of his physical disabilities and believe he's dismissive of the risks. He doesn't really appreciate them. That's why he dismisses them. And therefore, he's not capable. And this was about half of the team, I would say. So we have a real split, real division between team members. Others, on the other hand, feel he's indeed capable, and thinking about it from a legal consent point of view, and that others deem him incapable and unrealistic owing to his extreme positive outlook. So it became a matter of, okay, he's so positive about this. Is there something wrong with this picture? Next slide, please. I think that one of the main overriding questions from an ethics point of view, which was shared with the team, was this: how do we support his personhood? That is, his sense of who he is, the values that he holds dear that contribute to who he is as an individual, that contribute to his identity, which is obviously very, very important, which is also defined by his hopefulness and his positivity in the face of what professionals feel are unrealistic goals. How do we reconcile that? Next slide, please. Now, I put in a slide or two about moral distress because it really began to be an issue amongst the team members. And they were feeling a great deal of moral distress as professionals. And unfortunately, this presentation doesn't allow for a lot of time to address this very important topic, but we did spend quite a few sessions with the team, identifying their issues of moral distress and helping them identify what supports we could put into place to help them. So this could be an entire presentation upon itself, and unfortunately we don't have a lot of time. So next slide, please. Let's spend a little bit of time looking at the Ontario Healthcare Consent Act. What does it mean to be capable? Well, we know a few things, and this is based on the law. We know that capacity is decision-specific and time-specific. We know that somebody can be capable of a particular decision at one time, but not at another, for example. And if we cannot say that somebody is not capable of any decision, you know, if they're conscious anyway, we have to always figure that out very specifically around the specific decision that's being put on the table, or sorry, the treatment that's being put on the table and that we're looking for a decision. So a patient is presumed capable, and we have to remember that. Capacity is presumed unless there are reasonable grounds to believe otherwise. So we know that a patient is capable to consent to or refuse treatment if he or she is, 1, able to understand the relevant information, and 2, able to appreciate the reasonably foreseeable consequences of a decision. Next slide, please. So what's so complex about capacity, and is it even such a complex issue? Well, it can be. It isn't always, but it can be a complicated undertaking, and it certainly was in this case. Because again, we know it's decision specific and temporally located. And just to repeat, is Mr. Wilson able to make a competent decision about issue X at this particular time? Now, we also know that many patients may have significant fluctuating levels of competence, and that's going to be related to, as you know, any number of factors: mood, time of day, memory impairment, other diagnoses such as psychiatric illness, medications, etc. Next slide, please. I think it's very important to understand that notions of competence are enculturated. In North America, there's a very dominant view of competence, and that's very cognitively based, dependent on intellectual mental reasoning. This can overlook relational and affective factors integrated to meanings that people find in their lives, and for example, emotional intelligence. But the dominant cultural notion of competence in North America is very much related to intellectual and mental reasoning. And I think we need to keep that in mind as well. Next slide, please. Just a few, one, I think, very important quote and a couple of points to make further about capacity. When assessing competence, emphasis should be on the ability to make and execute choices, not on the wisdom or folly of the choices made. And I'm quoting Michelle Silberfeld, who was at Baycrest and had many contributions in the capacity clinic that he oversaw. So I can't stress enough the importance of understanding capacity in accordance with the person's values and interests. We all make decisions that others regard to be against our interests, but based on sound understanding and appreciation. For example, smoking, eating foods that we shouldn't be eating, driving above speed limits, etc. We may know that they may be dangerous acts unto themselves, but if we know, if we understand and appreciate the consequences, then we're deemed to be capable. Next slide, please. Now, I'm going to just quickly go back to the principle of autonomy. We know what it means. If we're not deemed incompetent, in other words, if we're deemed competent, one has a legal right to make what others might consider to be bad or stupid decisions. However, once you're deemed incompetent, one no longer has the legal right to make what's considered to be, quote, a bad decision. In reality, however, we usually allow so-called incapable or incompetent people to make bad decisions if we determine that the risks or consequences to be of no or little minor importance. So the belief in respecting an incompetent person's autonomy or dignity is upheld when we perceive no or minimal harm to the patient. So we don't worry about their capacity when the consequences are of little risk or harm. And at a minimum, I would suggest that incompetent wishes should be respected if they don't conflict with the best interests of the client. Next slide. So for the principle of beneficence, as we looked at before, again, As healthcare providers, we attempt to act in the best interests of the patient and to reduce harms. I think it's very important to consider the patient's values when we act in the best interest of the patient. Again, the values should provide a context to decision making. And in reference to the incompetent patient, typically best interest is understood through the lens of protection. And from sort of a psychological stance, we often move to the position of how can we protect this client? And I'm just suggesting that we think very carefully when we move to that position. Next slide, please. Oh, thank you, we're already there. Okay, so let's look at some important considerations regarding risks. We know that risk produces positive outcomes because without risk, we would have no opportunities, we would have no creativity, we would have no new inventions. And on the other hand, it also produces negative outcomes via hazards. So how do we create balance between taking risks and mitigating risks? It's important to ask, what are the potential hazards to taking the risk? And I would suggest that it's equally important to ask the next question. What are the risks of not taking the risk? So whenever we're faced with a situation, I think we need to ask that question as well. Not just what are the risks or hazards of taking the risk, what are the potential harms? What are the harms or the risks of not taking the risk? And how to answer these questions from the lens, not only of our lens, okay, and to be careful about not projecting our own opinions, but through the lens of our clients' values and personal comfort with risk-taking. Next slide, please. So this concept of risk is very complex, actually. So it's important to consider the value each of us applies to the notion of risk. Is risk a good thing, a bad thing? How would you answer that question? How do we evaluate it? And we have to consider risk in terms of all the stakeholders. There's no question about that. What's the personal comfort with the specific risk being addressed? Well, Mr. Wilson had a very high comfort level with risk due to his value belief in positive outcomes and positive attitude. For example, about decannulation. Staff members did not have a high comfort with this whatsoever, mostly anyway. Next slide. As I said, we have to be very careful not to impose our own values of risk onto others. When values clash, should concern of client safety trump Mr. Wilson's personal comfort with risk and desire for greater independence? And how should the value of patient-centered care influence staff in decision-making? What is the role of patient-centered care in a situation like this? Next slide, please. I would actually, if we have time in the discussion period, love to hear any reflections that you might have about the role that client-centered care should play when we're looking at situations like this. Now, safety is a very crucial value, and I'm not trying to impart a different view of that. However, I think a very important question that Vidi asked several years ago, should safety eclipse other principles and values such as autonomy and dignity? We can likely agree it shouldn't be the singular purpose of client care and treatment, but how do we actually reconcile safety, autonomy, and dignity? Next slide, please. When we talk about the dignity of risk, what are we really talking about? So this is the principle of allowing an individual the dignity afforded by risk-taking with subsequent enhancement of personal growth and quality of life. We have to balance dignity with risk. Now, this doesn't mean we always allow people to exercise their choice, because that's part of dignity. Next slide, please. And we're coming to a close in a few minutes or less. I think very quickly, and I apologize for not being able to give this a deeper sort of understanding, but I think we have to consider barriers when we think about how it is if we want to enhance the dignity of risk in the environments and that we live in the organizations we deliver care for patients. A barrier would be cognitive impairment on the part of a client. It's a barrier, but it's not necessarily an elimination of what a client wants to do. But it is more complicated if there is an cognitive impairment. Staff anxieties and fears may get in the way of allowing this notion of dignity and risk to flourish more. Certainly individuals' perception of risk, and I've mentioned this a few times today, bureaucratic processes, laws, insufficient funding or staff numbers to be able to allow for this to occur in a safer way, knee-jerk reactions, and some of these barriers are going to be more easily reconciled than others. And next slide, please. Enabler, clear processes and protocols, having policies in place, legal support, sufficient funding, a supportive philosophy of care, support for management, education and training, understanding the person's values, that should be at the very top, collaborating to find solutions. Next slide, please. Again, really important enabler is a narrative view. What is the client's story? Had we not understood the client's story and how it is that his life held many challenges and there was a legacy intergenerationally of hope and optimism, we wouldn't have really understood him and been able to work with him in, I think, as authentic a way as we were. Reflecting on own values, beliefs, and assumptions, personally and professionally, and identifying when team members' values clash, and talking about that and trying to reconcile that. Making them transparent. Ensuring clear boundaries between us and the patient so we're not projecting our own values. Advanced care planning, very, very important so that treatments and care options are seen through the lens of patients' values and beliefs, and addressing moral distress on the team. We need, when we talk about the narrative view at the top, what is the client story, it's important to take the time to really understand this. What meaning does the client ascribe to their situation? What are their beliefs, hopes, fears, and deepest wishes? That's it.
Great, thank you, Dr. Sokolowski. We now will answer any questions. While we're waiting for some questions, thank you for, I always find an ethicist point of view very helpful in these very challenging cases. Thank you for bringing us back to kind of ground us on the principles of the bioethic principles, but also reminding us of the organization, the values and principles of our organization, and certainly our colleges, etc. The one question, I have many questions, it's an area I spend a lot of time thinking about, but one question I am wondering when we talk about sort of the clash of values between, clients and your case study was also, it sounded like perhaps maybe family member and staff. I think about too how as clinicians we're really kind of encouraged to make decisions based on, evidence-based practice. So we're sort of that rational decision maker, and we're approaching these kind of questions with the client and family or patient and kind of with the same expectation. But somehow, or sometimes I feel, we also make decisions on emotions, and I think also as clinicians we do in these cases when we have that fear around the potential harm that the client could have. Like, do you notice that when you're guiding your teams through this decision making, that there is a difference to how everyone approaches it?
Absolutely. And when you can feel the tension in the room, there's going to be differences of opinions. And yes, absolutely, they need to be evidence-based decisions. So rationality is really, really important. I will I will always ask people to take a step back and to identify, help them go through a process when this kind of situation occurs of making the values that they hold based on the organization, their professional colleges, and just who they are as people, right? To try to make them more transparent. Because at the end of the day, we all have the best interests of the client at hand, right? And I try to normalize that. And then I offer people the opportunity to make their values transparent to the group, you know, and particularly to sort of struggle through the notions of, okay, well, how far apart is that even from the values that are being espoused by the client, right? And when are we really in the situation we're projecting our own values? Like, is an opportunity to really own the values and to ensure they are aligned with the organization and the professional codes, and that we have that they're evidence-based. The decisions are evidence-based, because even what somebody offers as treatment is going to be somewhat subjectively determined by the practitioner. Of course, it's going to be based on medical evidence-based practice, right? Rational decision making. But one's own values are always being projected. I don't want to say that we stop that, but I think when we become aware of it, we can control that more. I hope I answered your question, maybe in a meandering sort of way, but.
No, that's helpful. I mean, just walking us through this, you know, the process of which, you know, you take your teams is very helpful. Thank you.
You're welcome.
Any other questions?
You mentioned how do we as healthcare workers evaluate the risk versus benefits? If someone's safety is at risk, how do we evaluate the risk? Yeah, how do we evaluate the risk of choosing safety or letting the client choose for themselves what they would like?
Well, it's an excellent question. Thank you for that. It's not easy. Like in this, sometimes it is, and sometimes it's not. So there's a number of realms that we would have to consider. One would be, again, the evidence-based practice, right? What does the science have to say? What does medicine have to say about what we're doing? Let's say decannulation. There was apparently good evidence that it was extremely risky and probably not going to, not that it wouldn't work, but there would be medical harm or suffering and harm. Now, so that would be sort of the evidence-based, right? So one could say, no, we don't want to do that. But then you have, in terms of the autonomy, you have a patient who says, I'm okay with taking that 5% chance that it'll be okay. Like, I'm okay with that because I've been a lucky man and I'm riding on a lot of luck. And if Mr. Wilson is able to understand and appreciate the consequences, which he seemed to do, although others said he can't be appreciating it if he's willing to take such a high risk. But that's the value. That's an autonomy issue around. But this person has a high risk appetite, and he's a gambler in the sense that he's willing to take that gamble and win the 5% chance that he will be okay. So from a strictly evidence-based practice, if it would make sense to say, no, that's just too much harm. But is it up to us to say no to him because we're not comfortable with that kind of risk, right? So if we deemed him capable, remember, there were those slides that said, we don't have to agree with what the person's decision is because that's going to be based on his own value system. And part of his value system is to take risks that may be very dangerous because the slight chance of a positive outcome is extremely, extremely important to him, and he's willing to take the gamble. Does that help? And so that would be sort of like what a conversation might look like.
Yes. So do we go with the patient? I still don't.
Well, we did. Yes, we felt, at the end, we felt he was capable. and that he was willing to take the risk, and he was willing to die for it if that's what would happen. And it's a proposal of a treatment. He has to be made very, very aware, and we need to be really clear that he's truly able to understand the benefits, which he did, but also the consequences. Now, some people said, well, someone who's going to take a 5% chance is not clearly thinking, and that's a value difference. That's not necessarily excuse me, a capacity issue. So we have to be careful. If someone doesn't agree with us, we don't say they're incapable. They have a very different value set and a very different risk appetite or ability to live in a world where risks are high. But that's something that this person actually prefers. So yes, it was done. Remember, we have to also assume capacity unless we can prove otherwise.
Great, thank you. We have another question in from Dr. Rabaru. Just a small point on the terminology. Please clarify the clinical concept of capacity versus a legal concept of competency. Thank you.
Interesting question. You're having me pause here. I mean, the clinical is supposed to reflect the legal. So we have to follow the laws about how we assess capacity, right? And I think the clinical piece is when we take into consideration the values that are shaping the person's interests. Like, let's say we had a situation where there are 5 treatments that could be different treatments that could be offered. We may, by knowing the patient's story, and when I say that, what I mean is their values, their wishes, etc. The more we know them, the better the treatment can be customized. If we know that somebody, for example, is near death and spending really good time with family members present for the last couple months of one's life is extremely important, for example. Well, if one of the treatments that are being offered on the table is something that will, for example, reduce a person's consciousness, it may treat their pain better, it may even prolong their life, and they will be sort of in and out of consciousness, or just not as conscious, okay, not as fully awake and as vibrant as they could be. Maybe you don't even table that one, or you could table it to them, but you would know that if they want to be awake and able to communicate, because that's really extremely important to them at end of life, then treatment A may not be a good match for them. So I always think it's important to understand, can they understand and appreciate the risks and benefits of each? Not just from a medical point of view, you will be sleepier, etc. But what does being sleepier mean to you from a qualitative, quality of life point of view? So I think it's taking the legal definition and trying to customize what that means with each patient according to their values and wishes, and helping them go through that process. Ultimately, it's their choice if they're capable.
Thank you. While we're waiting for more questions, I have another one. Yeah. I'm just wondering, because I think I heard you speak on this back in, well, it seems like a fog earlier this year, perhaps. Yes. Okay, and so certainly with him being in complex continuing care, there is some time to be able to work through some of these issues with the team. But do you see the time, like with maybe perhaps teams and other programs where the length of stay is shorter, do you see length of stay impact on patient-centered care or patient-centered decision-making, especially when it comes around, this topic of concerns about their own safety?
Great question. Thank you for that. Absolutely. Absolutely. It's a process, right? Now, if you have less time, you have less opportunity, but you could still focus on it. In advanced care planning, this is where we have the opportunity to sit down with the patient, and if the patient's not capable, to have conversations, and it's not usually all or nothing. They may give permission to include family members who may be able to also contribute. When you start asking questions about, what are the patient's goals while they're in care, you can certainly make that a priority, from the very beginning, from when the patient first arrives, in getting to know the patient. I remember many years ago, I learned about a particular hospital that before the medical team was allowed to access the medical chart of the client, they had to access what they called an autobiographical chart, where the patient had undergone some interviews, whether that was with intake or the social worker right when they arrived, to get a sense of who is this person. So you couldn't access the medical chart unless you had read that chart first. So that when you're reading about the medical conditions, you have a context of who that person is and what some of their wishes and their values and goals of care might look like. I thought that was brilliant. I haven't seen that anywhere else. So they first asked, who is this person? Then they asked, what are the medical issues, as opposed to the other way around.
That is, very interesting.
Mm-hmm.
Thank you. I don't see any other questions, so I do want to take this time now to thank you again for such an informative presentation. It was such a great opportunity, and for us to kind of see how you as an ethicist guide us through that clinical decision making, through your lens, but very much grounded in a very real case that we could easily sort of identify the tensions of so many different values and principles. So thank you for joining us this morning.
You're very welcome. It was a pleasure. My only wish was that it could have been in person.
I know. We miss seeing you. It's such a dynamic topic that it lends itself easily to such great conversation. So thank you.
My pleasure, and thank you very much again for the opportunity to have this discussion today. And I wish you all well and to be safe.